We're going to be talking about weight loss today here on the Exam Room Podcast, brought to you by the Physicians Committee. The latest statistics show more than 3 out of 4 people in the United States are overweight. More than 40% fall into the obese category. Clearly, this now falls under the epidemic category. And so today we're going to be talking about the latest innovations when it comes to weight loss, drugs, bariatric surgery, diet, lifestyle. What works best? Do they all work together? Can they work in conjunction, or what is the magical solution? For the answer, we are going to turn to the chief of obesity medicine at Northwell Health and the Zucker School of Medicine at Hofstra. With that, we welcome Dr. Jamie Kane back to the exam room. Great to see you again, Doc.
Thanks, Chuck. Great to be here.
I'm thrilled that you are here, especially seeing as though I know that you just had some recent surgery, so I want to extend the best on behalf of myself and the exam roomies for a swift recovery.
Thank you. That's meaningful. Thanks.
Obesity medicine. 2 words put together. It's really kind of interesting. When you hear those 2 things together, it really kind of does drive home this point that even though obesity is so normalized in our society and even globally now, it is still a disease, isn't it?
Yeah, I think that's in the last, 5 years, and you could talk about the intention behind it, but there's really been a lot of talk about changing the terminology into saying this is a chronic disease. It's not just a lifestyle choice. Now, within that, there's a lot of subtlety, but it definitely is. And anyone who's ever gained a lot of weight and taken it off or tried to take it off and dealt with the long-term consequences could echo that.
It's interesting. I think it's so weird to me that there is still this stigma against being overweight, given the fact that literally the vast majority of the population now is, and yet we still kind of have this I don't know. There's this taboo, there's this stigma surrounding it that I think certainly only compounds the issue. Not to throw you right into the boiling water, man, but where do you weigh in on the body positivity angle of this, where I feel personally, as somebody who used to weigh 420 pounds, that it's never okay to body shame, but at the same time, I feel like if we don't address the problem head on, we really are pulling the wool over our eyes and we can't improve our health.
So yeah, I would say we probably fall in the same camp there. In terms of finding the balance there, I do agree it is a chronic disease, and making people feel bad about it, or anti-obesity bias, which we're going to be doing some research on that, is really prevalent in every part of society, although it's usually at its worst in the medical system. And so that has no place anywhere. That said, just because there's a normalization of obesity and overweight in a large part of the world now, that doesn't make it not a disease. And so I think we need to address it as such. That would be like saying, diabetes keeps increasing, therefore let's normalize it and just say it's okay to have diabetes, and it's not, right? So I would kind of view it the same way. If it is a disease, it is a disease, and we need to do something about it, just in a non-judgmental way. And I think that's the big difference. And in a being both open-minded but also considerate of the whole process. And right now, the anti-obesity bias is so strong that it affects, who pays for what and how we actually get to treat our patients. So that's kind of where I fall in it. And I think sometimes too often like the popular media likes to say, well, if it's not this, then it's the exact opposite. And we know that there's some hybrid, because as things stand now, the people who have to end up making different choices and changing are the patients, even if it's not their fault. They're put into this, rampantly obesogenic environment.
Give me some specific examples of obesity bias in medicine. Let's see if we can drill down here. I've had other doctors in the past come on and talk about how they kind of had this epiphany after a while in working with their own patients, where maybe they wouldn't have given as much time or as credence or had as much hope for a particular patient who was struggling with their weight. not necessarily writing them off as a lost cause, but certainly didn't exactly hold the same hope for that patient as they would somebody with a normal BMI. What kind of challenges does that present from a medical setting?
So research has shown in the past that cases of bias happen particularly strongly in medicine. Um, and things like you walk in the room, you see someone with obesity, and right away, you might not have explicit bias where you think you act out against the patient, but there's an implicit bias of that, what you were saying, that sense of hopelessness, the thought that someone with obesity is inherently lazier or less capable or less interested in their health, and therefore the physician might not put as much effort into it. Another side that we see here, and I know we'll probably get into talking about the medications that are so popular right now, is the thought that more advanced options, like like the surgery or medications, require a certain level of effort on the part of the patient beforehand to prove that they're worthy of more advanced treatment, even when they're struggling and have a lot of problems. Whereas you wouldn't say that about diabetes or hyperlipidemia or hypertension or cancer, even though all of these are more lifestyle based than anything else. So I think these are things that we tend to fight against a lot, to make sure that we understand that there's both explicit and implicit bias, and to make sure that we're normalizing the thought process of this person. If this is a disease and this person is suffering and there are other things associated with it, we want to focus on the long-term aspects and be able to get to them, and not have them go through extra hoops because they did this to themselves.
You use the term, you walk into a room and you see someone with obesity, as opposed to saying that you saw someone who was obese. What is the distinction there? I have had experts on the show in the past who have really gone to great lengths to always say it needs to be someone with obesity. Is that to protect the patient's feelings, or is that because we're talking about it in terms of obesity being a disease, much like the same way you would say you walked into the room and saw someone with cancer?
Correct. I think the latter there. If it is a disease, it is not necessarily defining of who the person is. And you say, theoretically, you say an obese patient or an obese person, as opposed to a person with obesity, then you're making that like the defining characteristic for them. And it's part of kind of changing the mindset. I'm never too into semantics, but this is one that stuck with me, and we do a lot of teaching, and so we make sure that the younger generations get this, just so they can be more sensitive to the subject, on both from the patient side and respecting the medical side.
All right, let's talk about these medications. I know that that's going to be a hot topic at our panel at the International Conference on Nutrition and Medicine. By the way, really looking forward to sitting down with you and Dr. Garth Davis, Dr. Jim Loomis, Dr. Neil Barnard. A whole bunch of us are going to be, Dr. Steve Loam. We're all going to be on the stage together for, I believe, a 2-hour panel
Yeah, that's gonna be a
on
good
that
time.
Friday. So that'll be Friday, August 11th. But the conference runs August 10th through 12th at the Grand Hyatt in Washington, D.C. By the way, you can get your tickets right now at pcrm.org/ICNM. I mean, just a amazing lineup of speakers. But one of the things that is likely to come up at the panel, obviously, are these weight loss medications. And getting ready to speak with you today, I came across a story from Bloomberg, and it was talking about Weight Watchers really shifting their model to go with a medication first approach. This company has actually, Dr. Kane, gone so far as to purchase a telehealth company so that they now can prescribe Wegovy, Ozempic, and the like to their clients. Um, that to me sounds like a medication first approach. I'm curious if you can help kind of break down the pros and cons of going that route from the medical perspective, and then maybe we'll get into it a little bit about from the patient perspective as well. What's your take on these weight loss medications?
Well, I think first is not to say that medications equals capitalism, but this is capitalism, right? I mean, this is business. I think a lot of companies like Weight Watchers are struggling financially, and right now the medications have gotten better, so there's a craze for the medications, and so they're going probably in a way that allows them to profit off of what's going on, or stay solvent, or I'm not familiar with the exact details of their finances, but odds are that's the case. And I know that a few of the startups that happened, with colleagues of mine, over the last 3-4 years have been struggling because, how you figure out the medication and make a business out of it is complicated. But I think my guess is Weight Watchers' primary aim here is not how do we get more people to be healthy long term, but how do we stay in business? So that's just my take on that. Sorry,
Yeah.
and you did ask me some questions.
No, but then that goes to like, medication first approach,
Oh, right, right,
and then you get into the diet and the lifestyle factors.
right.
I agree with you. Like, I'm not sure that, as you said, that is going to be the long-term solution. Um, it looks like something might be missing from the puzzle. But then there's also the big part of me who had gone up and down the scale so many freaking times in his life and was so frustrating and blew through a bunch of these programs, where I know that there was also something else missing from what it was that they were offering even before they bought this telehealth service to be able to prescribe. So I mean, just the medication first approach in general, whether we're talking Weight Watchers or anyone else, what's your take? Is that missing the mark, or is that really where we should be started? And then after that, we can address the other factors.
Well, I think that it is, from a, and I'm talking aside from Weight Watchers, right? Just from the obesity medicine side of things. I think um, it's an interesting discussion to be had, because we know that the effect of these medications is less, if your lifestyle is not on point. For instance, like eating high fat foods blocks the efficacy of GLP-1, which is the GLP-1 hormone agonists, the meds that imitate those hormones and act in your brain and your gut, that really decrease the appetite and help you lose weight. If you eat a high fat diet, it kind of suppresses that, right? So just taking the med and not doing anything else with it isn't so effective. On the other hand, how many times in your own life have were you going to do an intensive program and then it didn't last, or you were unable to keep motivation up, or whatever the issue was? So it's kind of hard to deprive people of that. I'll say in my own practice, and I think we talked about this before, about 30% of my patients were on medications when I first started my current job at Northwell about 8 years ago, and now that number is probably closer to 80, if not a little bit higher. So even though the bulk of our discussion, we want to be about lifestyle, and we keep emphasizing that long term, without the lifestyle, it's going to be hard to either get off these meds or keep the weight off. It's also hard to deprive people of medications that are now, have 15, 16, 20+% weight loss averages, given that the majority of people who would just try a lifestyle intervention don't stick with it and even get to that point. So, I'm of two minds about that.
Yeah, I got you. It's definitely not an easy answer, and I would be hypocritical to say, well, absolutely don't do it, given the fact that I had bariatric surgery. I felt like it was a last resort. I had tried a lot of other things. But that then brings me to the fact that no matter how a person initially loses weight, there still has to be that diet and lifestyle intervention, because without those two things, in addition to whatever else you're being prescribed, whatever other program you're on, to me, that long-term success is not going to be there. So that these medications or a surgical intervention, it's just going to be another stopgap that ends in heartache for the patient. So how do you marry these two things together? Because there's a big part of me who is concerned that, as my grandma used to say back in the day, you can't put the horse back in the barn. And the medications are already out there, right? So how do you marry these two things together with a long-term successful program for the patient?
Yeah, so I think right now how we're doing it is, if patients want medications, or we think that it's more appropriate to start, we give that advice, and we keep emphasizing, these are the other pieces of the equation that are really necessary for long term, and think of the medications just like you could think of the bariatric surgery as a tool, not a cure. Um, and that's, I think that's the way you look at it. It's hard it's hard to be like in a camp that says, well, a lot of my colleagues at other universities are, they just bounce from medication to medication to medication, or add and add and add and add, and then just say cut calories, and I think that the disease and the things associated with it and the human brain require such a complicated set of circumstances to be able to keep the weight off long term. And I think you're a great example of that. The surgery was a tool, but I with all due respect, I don't think you're in the position you're in health wise without the lifestyle. And I think that makes you like the poster child for how surgery really should work, or how medicine should work, which is using it as a tool. There's some changes that were temporary that help with weight loss. There's some changes that are permanent that happen. But with that's what we call an adjuvant, in addition to the intensive lifestyle stuff that you've been able to succeed with over the long haul.
Yeah, absolutely. I mean, it's so funny. Like when I went even for the initial consultation for the surgery, they use that term. It's a tool. It's a tool. It's a tool. But I can guarantee you, everybody in that room who was a candidate and considering undergoing that procedure, myself included at the point, was like, tool my right foot, like this is going to be the solution. And all of our chips were being put into that basket. And the thing that, looking back on it was really concerning was that the number one question that was being asked among the patients was, when will I be able to eat this again or that again, or whatever their favorite foods were, right? So already they're just looking at, okay, well, I'm going to suck it up. I'm going to do this short term, but pretty soon I'm going to be able to get right back to it and I'm going to be okay. Hindsight is 2020, man. And like, I was not going to do, fast food or anything like that again. But certainly I think that there was a lot of things in there that I was ready to put back on my menu as quickly as possible. Like, how do you relay that to the patient without really scaring them, man? Because again, Dr. Kane, it's like, if you tell somebody at that point that you're never going to be able to eat a hamburger at McDonald's again, you're never going to be able to have that meat lovers pizza from Pizza Hut again, like that's going to freak them out to the point where they may straight up walk out of your office, man.
Yeah. I look, that's complicated. I probably look, I have a saying that like, I find the love before I walk in the room, or now it's like click on the screen, since we do a lot of virtual work now. With all my patients, even if they're philosophically not aligned with me on this. That said, I believe that the patients are owed the truth, and they can make informed decisions. I think their decisions end up being skewed by the body chemistry and their history, that makes it complicated. And I sometimes ask people to trust what I'm talking about, and I mentioned the science and I mentioned studies, and to make it easier on them. But the problem is that it's not like you can't eat a McDonald's hamburger, you shouldn't eat a McDonald's hamburger, right? And now we're back to personal decision making, and where I think that you can't blame a patient for slipping up and eating a cookie or McDonald's hamburger if they're exposed to it. At some point, the accountability has to be there. That like, I understand what these things are doing to me, and I would prefer to live a life without them, is the ideal point from which I can work with someone.
Mm. Yeah, it's hard, and the person has to be ready to change. I think that if somebody's walking into your office for an appointment, they're at least closer to wanting to change, which definitely makes the
I have a
conversation
biased
easier.
population, right? So
Yeah.
some of the people that I've trained recently, that I've hired recently, have come from like inpatient work, and in the inpatient work, they're not seeing healthy patients or patients with obesity who really want to get a hold of their health. They're seeing people who have the complications from the uncontrolled aspect of it, and they haven't asked to be hospitalized. They just got sick, as opposed to patients that voluntarily come to see me. So there's a difference, because a lot of their time is spent kind of motivating and figuring out and salvaging. Whereas I have the luxury of being able to dive more deeply in patients who already come with some degree of motivation. I mean, it's not always exactly what I'm looking for in terms of what they're motivated to do, but it makes it a lot, the conversation's a lot more direct and honest. And if people came voluntarily seeking out my advice, then I think I owe it to them.
Absolutely. Do you find that patients are receptive to those, like, really curt, here are the facts. I'm not going to sugarcoat this for you. This is just the reality. Are they receptive to those types of messages?
Um, okay, there's different types of receptive, right? So are they receptive? Like, do they understand what I'm saying? Patients with a modicum of medical sophistication, yes. Then they'll say, yeah, but. And this is in the world, particularly in the world of these new medications and the medication popularity. A lot of people are like, yeah, but I don't. How do I get to, like, keep my old lifestyle and still lose weight? And that's a difficult spot for all of us to be in, right?
Yeah.
And I think the new meds allow some of that, but it's not going to last. And that's the issue that we have, is like, yeah, you can look at the scale 25, 30, 40 pounds down, but years from now, what's this going to look like?
And what is the long-term efficacy of these weight loss medications? It seems like there's been an explosion of them recently, and a lot of us are just now learning about them. It makes me wonder if there have been any long-term studies about the success rate here. How long does that weight stay off? Is it permanent? Do you need to stay on them permanently in order to have that success? What do we know there?
The answer is, right. Like, does that work? Uh,
I mean, we may want a little bit more
a little
clarity
bit
than
more detail. Yeah. So generally speaking, when I talk about medications, and I've been asked to lecture, like once, twice a month now, just on medications. I like to show a graph of an older medication that's now off the market. But what you see is weight loss for in the 3 to 6 month range, and then a little bit of a taper, and then a slow weight regain, slow after that. Into a year or two later, where they've still maintained a decent amount, but not a ton of weight loss. And then they compare to the people after a year who stopped taking the medications, rapidly back to where they came from, and probably a little bit over.
Hmm.
So in general, that's the trend. And new medications have been approved for indefinite use. Most patients are not interested in that. And what we do when we're tapering people off of medications is making sure that at that point, we have a lifestyle and a plan in place. We know that exercise, particularly in the weight maintenance phase, is really important. And what you eat, trying to get people on a diet that is, they kind of have two rules. Some people, we can get right into whole food plant-based, that those people have amazing success. But the two rules I use are: one, food should be as unrefined as possible; two, it should be as little animal or as much plant as possible. And you combine those two things, it puts the ideal at whole food plant-based, but we get close to that. And if they have a system that works for them and they kind of buy into it, and then they have the best fighting chance.
Oh boy.
But there are a lot of what we call metabolic adaptations to having lost weight, whether you have surgery, whether you have used meds, whether you use a combination, whether you're just doing it with diet and exercise. There are metabolic adaptations that slow down metabolism, increase appetite, and so you're always fighting against that. And we have lifestyle-based mechanisms to increase your metabolism, right? Exercise. We have lifestyle-based ways to decrease appetite by eating kind of a high bulk, high fiber diet that made up of whole plant foods mainly. And that's actually the most efficacious way to control appetite, for multiple meals at a time. And so moving people in that direction at least takes up part of what those medications were doing.
Gotcha. So, just for clarity here, when you say metabolic adaptations, is that the body kind of changing to work against, the drugs or the surgery? Because I know that, even though my intestines essentially were rewired inside over time, that malabsorption issue with bariatric surgery becomes less and less because the intestines adapt and it finds a way to absorb more and more. Is that kind of the same thing that you're talking about?
Well, it's an adaptation, but the adaptation to losing weight or losing fat in particular, and the adaptation to chronically eating fewer calories is that your body, kind of assuming it's starving to death, will slow down and make you hungry, right? So you don't starve to death. Now, going from 420 to 320, you think I still have another 150 pounds to go, and yet your brain and your neuroendocrine system are thinking, this guy's starving to death. We better put the brakes on, right? That's kind of the easiest way to think about it.
Gotcha.
And that happens with modest weight loss, like 10%.
Gotcha.
Actually, it happens. Sorry, it happens with 72 hours of low calorie eating.
So, wow. Okay,
Yeah.
that's pretty quick.
And
Okay.
then after about I think it's, I'm sorry, pardon my memory here. It's somewhere in the 1 to 2 week range. I think it's 2 weeks of normalized kind of what we call isocaloric, like eating and exercising enough to match everything. That's how you would reverse it. But that doesn't take away the weight loss part. Once you've lost a lot of weight, then you're missing some of the hormones that are made from fat cells.
All right. We were talking a little bit about it, making sure that the patient was informed and that they have all the facts. So I would think that then when you're talking about prescribing weight loss medication, obviously the discussion about potential side effects needs to come up during that conversation. What are some of the more common known side effects of these weight loss drugs?
So, I mean, the different drugs have different side effects. The ones people are probably interested are what we call those GLP-1 receptor agonists, the things in the Ozempic, Wegovy family. Um, the very, very common would be stuff like, heartburn or reflux, and nausea. And that's because one of the ways that hormone works is it delays how fast food moves out of your stomach into your intestines. So food's just sitting there a long time. If you eat a heavy meal, a high fat meal, and so forth, things are going to kind of reflux more likely to reflux upwards and cause discomfort, or it could be nausea. And the hormone itself causes a little bit of malaise and nausea. We also see constipation, not in everyone, but not as commonly, but particularly people with a history of constipation. Um, and then on the more dangerous side, there's a potential risk of thyroid cancer. I say it with that tone of voice because 3 studies, large scale studies that have looked at this, the first 2 really didn't show much of an increase. The third one did. I have some pretty trustworthy people looking at the way the statistics were calculated from that third study that was looking at insurance claims from France. And it turns out like almost everyone has insurance there, so you get a good bunch of the population. And it looks like the thyroid cancers, both the more common, what we call papillary thyroid cancer, and medullary cancer, which has a mortality rate, did go up, but it's not 100% clear if that was, done correctly. But if you look at the older studies that were done here, there's a slope that looks like it's trending towards it, even if it didn't reach what we call statistical significance. So, I think there's suspicion, and it comes down to risk benefit ratios, and we decide what we're going to do, with the patient and based on their circumstances. And for some people, it's a no, and for other people, maybe. And then the other issue is that it decreases how hard the gallbladder squeezes. And so the risk of having your gallbladder taken out, looking at data from England's National Health Services, looks like it was about a double risk of having your gallbladder taken out. And this is a population that has a higher risk anyway, but even double that. You'll hear about stuff like pancreatitis. I have not seen it in over 15 years of these meds being out. But that doesn't mean that it's not possible. So we take it seriously and are judicious in who we give the medications to. If that's enough in the side effects, I don't know.
Yeah, that's a pretty good list. I mean, that'll take up some time on a commercial for sure. Question for you. You mentioned constipation, though, being one of those potential side effects. Could that also be a byproduct of somebody not necessarily changing their diet if they've been eating historically a low fiber diet, staying pretty much dehydrated. There's just not a lot to move through, or it's not going to be easy for things to move through the system. Could that be what is the issue here because they haven't modified their diet in addition to adding the drug, or is it the drug itself that's causing the constipation more
It's
often than
both,
not?
but probably more the drug. Yeah, because
Okay,
my patients almost always increase their fiber when they're working with me, and I still see it a fair amount.
gotcha.
Um, I have patients on very high fiber diets, sometimes with fiber supplements and lots of water and lots of exercise and stool softeners and all that. Just it sounds very much not like the reason I got into this field, but sometimes we do that for patients in whom these medications really are helping a lot. Um, and so I think part of it has to do with the transit from based on the hormones, because understand you're getting we have our own GLP-1 in our system, and I know Dr. Barner just sent out a newsletter, and there was, I think Pisharam did some studies showing that GLP-1 goes up when you eat a plant-based diet, but um, it doesn't go up at the same amounts. You're getting like super therapeutic amounts from these medications.
All right, let me ask you this, and we'll kind of wind down here. What is, the ideal candidate for this medication? My concern is that with these weight loss drugs now kind of being all the rage, people are going to turn to them, um, again, not as a last resort, but kind of as a first resort. Who would you say is the ideal candidate for these prescriptions?
So it's going to depend on as time is going on. In the next 5 to 10 years, there's probably going to be 5 or 8 new similar medications that have the efficacy of average 15, 20, 25% weight loss. And it's getting pretty hard to argue against them being part of the mainstream early treatment for patients in the need. I would say the candidates for these medications are going to be people with the ones out now, and some of the ones coming out soon are going to be people with known insulin resistance. Patients, some patients don't have what we call the satiety cue, so they start eating, but there is no off switch. And when they take these medications, a portion of patients said, for the first time in my life, I actually have that off switch. And no matter what I ate, I didn't really get it. For them, it definitely makes sense. There are people who've had bariatric surgery that have, stalled early or started regaining weight. Very often, they are very good candidates for this. People with certain hormonal issues like polycystic ovarian syndrome, very often without medications, no matter how healthily they eat and exercise, we get stuck. So I think those are kind of like no-brainer cases. And then the question is, for someone, let's say, you came to me back in the day, right? And you're relatively motivated, but you're interested in really going all out and losing 200 plus pounds. Are these meds enough? What happens when you take them and lose 50, 60 pounds, which is great, but then kind of get stuck? What do we do? So the question for patients like that is like, I often try to start without it, wait till we kind of hit a metabolic wall, and then go forward from that. So that's really where we are. I think the one place that we try to avoid is someone who's just trying to lose a small amount of weight and doesn't really have much in the way of medical issues, and they're planning on doing this as a temporary measure, as a jump start. That's pretty much a recipe for failure.
Yeah.
So we have to make sure that we're looking at this kind of holistically and longitudinally.
And I think no matter which way you kind of chalk it up or look at it, I think that we can all agree that this is a complicated issue here, Doc.
Oh yeah, and then we didn't even scratch the surface, right? I mean, I didn't go on any of my like capitalism rants. I think I did mention capitalism though, so I'm happy with
A
that.
little bit, a little bit.
Yeah, and just there was a great uh, op-ed in the New York Times today about administrative burden of medicine, and this is both on the caregiver and team side and on the patient side, that often blocks care, and we're in that zone right now. The health insurance companies, because these medications are so expensive and there are supply chain issues, getting these meds, talking about how to get the meds, have become, much to the chagrin of me and my team, uh, has become way too large a percentage of the time that we spend with our patients, rather than being able to go through these important lifestyle and psychological factors that I think are really the keys to the long-term maintenance.
All right. Well, look, plenty more to talk about. We're going to get into a lot of that at the International Conference on Nutrition and Medicine. Again, August 10th through 12th in Washington, D.C. Summertime is lovely in the nation's capital. So join us at the Grand Hyatt for 3 days filled with health information and knowledge, the likes of which you will find absolutely nowhere else. Continuing education credits are, in fact, available. And don't forget our big weight loss panel with Dr. Kane, myself. That will be Friday, August 11th. So many others are going to be there. Tickets at pcrm.org/ICNM. And Dr. Kane, I cannot wait to continue the conversation, my friend. Thanks for getting us going this morning.
Thanks. That's the best conference of the year every year, and the best food for anyone who wants to see that plant-based eating can be delicious. So looking forward to it. Of course, this is the third time I'll be speaking, and every time I'm right after lunch. So.
Yeah, man, there you go. Well, you're going up there with a full belly, man. Life is good.
All right.
All right, Dr. Jamie Kane. Appreciate it, my friend. Thank you.
Thanks. It's a pleasure.
If your health IQ is a couple of points higher than it was a few minutes ago, go ahead and like this video or subscribe to the YouTube channel. And to take it even higher, head over to Apple Podcast or wherever you get your favorite shows. Look for The Exam Room by the Physicians Committee. Hit the subscribe button there as well and help to make your world a healthier place.